Welcome to the deep dive. Today, we're tackling a really significant health issue, deep vein thrombosis, or DVT, specifically in the lower legs.
That's right.
We've gathered the latest medical research to really get a clear picture of, what DVT is, how doctors find it, and the current ways it's treated.
It's such a vital area to understand, and our sources, they really emphasize DVT is a major public health problem right here in the U.S.
The numbers are pretty stark, aren't they?
They are affecting over 350,000 people each year. And the impact, well, it's substantial. We're talking about a 30-day mortality rate around 6%.
6%.
And potentially contributing to, well, a staggering number of deaths annually, maybe 100,000 to 300,000. Plus the economic cost, even back in 2010, was huge, billions.
Wow, those figures really hammer home how serious DVT is. But the research also points to progress being made,
Absolutely. There have been positive steps.
like improvements in predicting who's actually at risk.
Yes, and better imaging ways to actually see what's happening inside the veins. And then there's the newer medical therapies, like direct oral anticoagulants. So, yeah, it feels like we're moving in the right direction.
Good. So the mission for this deep dive, then, is really to pull out the key information about diagnosing and managing DVT from all this material we've reviewed.
Exactly. And to present it in a way that's, clear and hopefully engaging for you, the listener.
Okay, let's get into it. How does DVT actually show up? What are the first clues?
Well, the tricky thing about DVT, and the sources stress this, is that the symptoms can be quite vague, really nonspecific.
So not always obvious.
Not at all. Some people might have zero symptoms, none, while others could develop really severe conditions.
Okay. But what are the common signs people do get?
Common signs would be things like a dull ache or pain in the leg, tenderness if you touch the area, some swelling,
Swelling. Okay.
redness, what doctors call erythema, sometimes a bluish color, that's cyanosis, and even a fever in some cases.
But a lot of those things sound like they could easily be something else, right? Like a pulled muscle or maybe just some fluid retention.
Exactly right. That's the big challenge.
Yeah.
Relying only on those signs can be really misleading. Our sources are clear. These symptoms can easily mimic other things.
Like what?
Oh, like a simple bruise, a skin infection, cellulitis, even things like heart failure causing leg swelling, or just inflammation of the surface veins.
Right. And you mentioned some more severe presentations earlier. Phlegmasia,
Yeah.
cerulea dolens.
Yes, Phlegmasia, cerulea dolens,
Mm-hmm.
and venous gangrene. Those sound alarming because, well, they are.
What happens in those cases?
Phlegmasia involves really significant swelling, that bluish skin color we mentioned, and a lot of pain. It's a serious blockage.
And venous gangrene.
That's thankfully rare, but it's critical. It means the blood flow out of the leg is almost completely blocked.
Mm.
This can, unfortunately, lead to limb loss.
Oh, wow. Even if the arteries are okay.
Even if the arterial pulses are still there, yes. And interestingly, our sources note this is most often seen in specific situations, like patients being treated for cancer-related clots with warfarin, or sometimes in a reaction to heparin called HIT, heparin-induced thrombocytopenia. With warfarin, it might be related to a rapid drop in a natural anticoagulant protein when the warfarin is first started.
That's a really concerning picture.
Yeah.
So if the symptoms are so variable and can mimic other things, how much can doctors really rely on just, the clinical exam and talking to the patient?
The research suggests not very much, actually. Clinical assessment alone isn't that reliable for diagnosis.
Really?
Yeah. A big review of studies looked at individual symptoms and signs. It found that only really a past history of DVT, or currently having cancer, showed some diagnostic value. They modestly increased the likelihood.
But no single symptom is a slam dunk.
No. And importantly, no single clinical feature is reliable enough to completely rule out DVT on its own.
That makes sense, given the variability. And it sounds like people often wait a while before seeking help.
That's another crucial point, yes. The delay. On average, people wait over 4 days after symptoms start. And for more than 20% of patients, it's actually longer than 10 days.
10 days. That must make clinical diagnosis even harder.
It absolutely does. The sources even point out that if you just rely on a clinical evaluation primary care without further tests, you might end up with inadequate management in over 10% of actual DVT cases because of these delays and the nonspecific symptoms.
Okay, so checking symptoms and risk factors raises suspicion, but it sounds like we definitely need more objective tests. Let's move on to those. First up, D-dimer. What exactly is that measuring?
Okay, D-dimer. It's essentially a biomarker. It's a fragment of protein that's produced when a blood clot dissolves in the body. So it indicates that both fibrin formation clotting and fibrin degradation breakdown have been happening.
So if the D-dimer level is high, that points towards a DV2.
It points towards clotting activity, but not necessarily DVT. That's a really important limitation to understand.
Ah, okay, so it's not specific.
Not specific at all, no. Our sources clearly list many other things that can raise D-dimer levels. Things like recent surgery, trauma, pregnancy, having cancer, infections, inflammation, even other clotting disorders.
So a high D-dimer is just a signal that something is going on with the clotting system, but it doesn't pinpoint DVT.
Precisely. It's a clue, but not a diagnosis in itself.
And I think I read the test itself can vary quite a bit.
That's also true. There's variability in the assays, the actual lab tests used. Some are qualitative, just positive or negative. Others are quantitative, giving a specific number.
Right.
They might target slightly different parts of the D-dimer molecule, use different units, have different reference ranges, even differ in how quickly they provide results. Some quantitative point-of-care tests might be more sensitive for ruling out DVT, but they're not universally available.
So comparing results between labs could be tricky.
It can be very difficult to standardize and compare directly. So the key for you is that a D-dimer result always needs context, the specific test used, and crucially, your overall clinical picture and pretest probability.
Okay. What about how good the test actually is at finding DVT when it's present? The sensitivity.
The reported sensitivity for DVT diagnosis varies quite a bit, actually. Depending on the assay, it can range anywhere from about 60% up to 96%.
That's a huge range. So maybe a negative D-dimer is more useful than a positive one in some situations.
You've hit on a key point. Because it lacks specificity, a positive D-dimer isn't very helpful in patients who doctors already think have a high chance of DVT.
Like if they have lots of risk factors and symptoms.
Exactly. Or in patients who are pregnant, have active cancer, just had surgery or major trauma, or are already in the hospital because D-dimer is likely to be elevated in those situations anyway.
Okay.
However, and this is crucial in patients assessed as having a low or intermediate pretest probability of DVT.
Based on things like the Wells score we'll discuss later.
Yes, in those patients, a D-dimer level below the established cutoff value suggests a very, very low probability of having a DVT. So it's primarily used as a rule-out test in those lower risk groups.
I see. And I saw something about adjusting those cutoff values based on age or risk.
Yes, that's an important development.
Yeah.
Researchers have looked at adjusting the D-dimer threshold to improve its usefulness, its diagnostic value.
How does that work?
Well, one approach is age adjustment. For people 50 or younger, the cutoff might stay at, say, 500 micrograms per liter. But for those over 50, you might use a cutoff of 10 times their age.
Interesting. Why do that?
It aims to increase the specificity, meaning fewer false positives in older people who often have slightly higher baseline D-dimers without sacrificing sensitivity too much.
And the other approach, adjusting by risk.
Right, adjusting by the pretest probability.
Yeah.
So maybe use a higher cutoff like 1,000 in low-risk patients, but stick to the standard 500 in intermediate-risk patients.
Has one method proven better?
A recent large meta-analysis actually found no significant difference between the two strategies. Both the age-adjusted and the probability-adjusted approaches had a high negative predictive value, meaning a negative result was very good at ruling out DVT.
Okay. So D-dimer is a useful piece, especially for ruling out DVT in maybe lower risk outpatients, but it's definitely not the whole story.
Not by itself, no. It really needs to be used in conjunction with clinical assessment.
Got it. So what's the next diagnostic tool? Duplex ultrasonography. That sounds more like actually looking for the clot.
It is. Duplex ultrasound has really become the first-line imaging modality.
Yeah.
It's largely replaced the older test, venography.
Why is that?
Several reasons. It's accurate, it's safe, no radiation, non-invasive, it's portable, generally more cost-effective. Plus, a big advantage is it can often help distinguish DVT from other things causing leg symptoms that aren't related to blood vessels.
Okay, so how does it actually see a blood clot? What's the main sign?
The primary diagnostic criterion is non-compressibility of the vein.
Meaning?
Meaning, when the person doing the ultrasound gently presses down with the probe, a normal vein will collapse, flatten out. If there's a thrombus, a clot, inside, the vein won't compress fully.
Ah, okay. Simple enough concept. Are there other signs they look for?
Yes. Secondary criteria include things like increased echogenicity within the vein, basically the clot looking brighter on the screen. Also, an increased diameter of the vein, absent spontaneous blood flow, or if the flow doesn't increase normally when the calf is squeezed.
And how accurate is this non-compressibility sign?
For detecting DVT in the proximal veins, those are the larger veins in the thigh and pelvis, it's very accurate. Studies report sensitivity around 97%.
Meaning it finds the clot 97% of the time it's there?
Correct. And specificity around 94%, meaning it correctly identifies when there isn't a clot 94% of the time.
That sounds pretty reliable for those bigger veins. Or are there limitations, though? Where does it struggle?
Yes, definitely limitations. Ultrasound accuracy decreases when looking at the smaller calf veins.
Okay.
It can also be harder to visualize very fresh thrombi or small isolated clots. And technical challenges arise in certain patients. Those who are significantly obese, have a lot of leg edema or swelling, have bandages or casts on.
Makes sense. Harder to see.
Right. Or even in patients who've had a recent DVT and now have recurring symptoms, it can be hard to tell new from old.
Are there other pitfalls?
Yes. Things like misidentifying veins, especially if there are duplicated systems, which happens. Systemic illness or dehydration can affect how distended the veins are. And some areas are just inherently difficult to compress well,
Such as?
like the iliac veins deep in the pelvis, the femoral vein where it passes through the adductor canal in the thigh, and the subclavian vein under the collarbone if looking for upper extremity DVT. And critically, the quality of the exam is very dependent on the skill and experience of the technologist performing it.
Right, the operator dependency. I also saw mentions of different ultrasound strategies, single limited, serial limited, whole leg. What's the difference there?
Good question. A single limited ultrasound typically just looks at the popliteal vein behind the knee and the femoral veins in the thigh.
Okay.
A serial limited strategy involves doing that limited scan first. If it's negative, but suspicion remains, they bring the patient back in about a week for a repeat scan.
Why repeat it?
The idea is to catch any potential calf vein DVT that might have been missed initially if it has extended proximally into those larger veins during that week.
I see, and whole leg.
Whole leg ultrasound, as the name suggests, examines both the distal veins in the calf and the proximal veins all in one session, potentially avoiding that need for a follow-up scan.
So why wouldn't everyone just do the whole leg scan then? Seems more comprehensive.
Well, there's some controversy around that. A whole leg scan might identify isolated calf DVTs that possibly don't require anticoagulation.
Ah, the distal ones we discussed.
Exactly. Remember, PE is less common with those. Guidelines from different groups are a bit equivocal or vary. Some, like the ACCP, suggest considering whole leg if follow-up is difficult or symptoms point strongly to the calf. Others lean more towards whole leg.
Have studies compared the approaches?
Yes, but they haven't found significant differences in overall test performance, like the risk of VTE after a negative study, which is very low, 1%, with either serial limited or whole leg strategies. Still, many centers prefer a whole leg just to get the full picture up front.
Okay. And what about the accuracy specifically for those calf veins? You said it was lower.
Yes, the sensitivity of ultrasound for detecting isolated distal DVT is lower, maybe around 63%, compared to that high 94% for proximal DVT.
So the overall accuracy for any DVT is pulled down a bit.
Right. The overall sensitivity for detecting DVT anywhere in the leg comes out to about 90%, with the specificity still high at 94%. And it's worth noting, these test characteristics can vary depending on the patient population, like their pretest probability based on the Wells score.
And you mentioned it's even less sensitive in people without symptoms.
Correct, which is why ultrasound screening in asymptomatic or very low-risk individuals isn't generally recommended. You might end up with more false positives than true positives. But the main takeaway is that ultrasound can reliably rule out proximal DVT in symptomatic patients or those with intermediate to high pretest probability.
Got it. Okay, that's a thorough look at ultrasound. Next up is venography. You mentioned earlier it's mostly of historical interest.
Largely, yes. Contrast venography, where they inject dye and take x-rays, used to be the gold standard. But because it's expensive, inconvenient, uncomfortable for the patient, and ultrasound has become so good, it's really fallen out of favor for routine diagnosis.
Is there any role for it now?
Maybe a very limited one. Perhaps if ultrasound suggests a proximal blockage, but can't clearly visualize the thrombus itself in the iliac veins. Historically, it was considered better for calf DVT than older ultrasound, but the clinical significance of that now is uncertain. It's kind of a golden backup for very specific, unclear cases after ultrasound, or maybe in patients with previous DVT where the ultrasound is non-diagnostic.
Okay, mostly historical. What about computed tomography venography, CTV? We know CT is used for PU.
Right. CT arteriography is great for looking at pulmonary arteries for PE. CTV, looking at the veins with CT, hasn't really become a primary tool for lower or upper extremity DVT yet.
How does its accuracy compare to ultrasound?
It seems to be pretty similar to ultrasound for detecting proximal DVT, so in the thigh and pelvis. Sensitivity and specificity are generally high.
Are there advantages to CTV?
Yes, a key advantage is its ability to evaluate the pelvic veins and the inferior vena cava, the large vein in the abdomen, which can be limitations for ultrasound. It can also potentially identify other causes for leg swelling, like pelvic tumors or something called iliac vein compression syndrome.
And it can be added onto a PE scan.
Exactly. Since adding CTV imaging might only add a few minutes to a CT scan someone's already getting for suspected PE, it's potentially attractive as a single test for both conditions.
But there must be downsides.
Definitely. Artifacts from metal implants can be a problem. Ensuring good venous enhancement with the contrast dye isn't always perfect. Interpretation errors can happen. And, of course, it requires intravenous contrast, which raises concerns for patients with kidney dysfunction. Plus, not all studies have found it sufficiently accurate, with some citing lower specificity or high false positive rates, especially for pelvic DVT.
So potential upsides, especially for pelvic veins, but also some significant limitations and concerns. Okay. What about magnetic resonance venography, MRV?
MRV uses magnetic fields to differentiate between moving blood and stationary tissues. It can be performed with or without a gadolinium-based contrast agent.
Is contrast better?
Generally, yes. Contrast-enhanced MRV usually provides better images, fewer artifacts, faster acquisition, better signal, more accurate, especially where blood flow might be slow.
And how does it perform for DVT diagnosis?
A large meta-analysis showed good overall accuracy, with a pooled sensitivity around 92% and specificity of 95% for acute DVT. Like ultrasound, it tends to be more accurate for proximal DVT than distal.
How does it compare directly to venography?
Studies comparing MRV to the older gold standard venography found MRV could be up to 100% sensitive and specific for femoral-popliteal DVT, the main thigh veins, but again, less accurate for the smaller distal thrombi.
So accuracy-wise for the bigger clots, it's in the same ballpark as ultrasound and venography.
Pretty much, yes. But MRV has some distinct advantages.
Such as?
It's particularly good at defining the proximal extent of a known thrombus and detecting isolated pelvic vein thrombi. One study actually found pelvic DVT using MRV in PE patients who had negative leg ultrasounds.
That's significant. Any other potential benefits?
It might also offer clues about thrombus age. Sometimes enhancement of the vessel wall itself on MRV is associated with acute thrombus.
Okay. What about the disadvantages of MRV?
Well, it requires the patient to remain very still for a potentially long time. It can't be used in patients with certain MRI-incompatible devices or clips. There's the risk of gadolinium toxicity in patients with severe renal dysfunction. Utilization can be an issue getting scan time in busy centers. And the image quality depends heavily on technique, like timing the contrast correctly and experienced interpretation.
So when is MRV typically recommended?
It's considered an appropriate option when ultrasound is non-diagnostic for suspected pelvic or thigh DVT, or sometimes as the initial investigation if there's a strong suspicion of a central or pelvic vein thrombus right from the start.
Okay, that clarifies its place. Now, the last diagnostic test mentioned is quite different. 18F-FDG PT-CT. You mentioned this is usually for cancer.
That's right. 18F-FDG is essentially a radioactive sugar tracer that gets taken up by highly metabolic cells. That includes tumor cells, but also inflammatory cells like endothelial cells, macrophages, lymphocytes involved in inflammation. So while PT-CT, using this tracer, is a cornerstone of cancer imaging.
It might pick up inflammation around a DVT.
Exactly. It's shown potential value in diagnosing acute DVT, possibly helping determine thrombus age, and maybe even differentiating an acute clot from a tumor thrombus growing into a vein.
Have studies looked at this specifically for DVT diagnosis?
Several studies have characterized its ability to detect acute DVT, yes. Fewer have examined its utility for direct diagnosis in practice. One study did show higher metabolic activity in thrombosed veins and reported excellent test characteristics for acute symptomatic proximal DVT.
But what are the limitations? Why isn't it used routinely?
Well, major limitations include cost, radiation exposure, availability. Yeah, it's not everywhere. There's also the potential for false positives due to other causes of inflammation or infection. And fundamentally, we just have limited clinical data supporting its routine use, specifically for DVT diagnosis right now.
Very interesting potential, but maybe not ready for prime time for DVT yet. So we've covered a lot of tests. How do doctors put this all together? You mentioned risk stratification earlier.
Yes, that's the key. Our sources emphasize that since no single symptom or test is perfect, the most effective approach involves risk stratification using clinical decision rules, like the Wells score, before deciding on testing.
To be more cost-effective and avoid unnecessary tests.
Exactly, without compromising outcomes. It involves identifying the patient's risk factors and grouping them based on their predicted probability of having a clot.
We touched on some risk factors. Can you recap the main acquired ones?
Sure. Acquired risk factors include increasing age, active cancer, prolonged immobility.
Like after surgery or long travel.
Precisely. Recent major surgery or trauma, estrogen therapy, obesity, pregnancy in the postpartum period, chronic inflammatory conditions or infections, a kidney condition called nephrotic syndrome, certain autoimmune diseases like antiphospholipid syndrome, and importantly, a prior history of VTE.
That's quite a list. Do they all carry the same weight?
No, the relative contribution of each factor varies.
Mm-hmm.
For instance, the risk after certain types of major surgery, like hip or knee replacement without prophylaxis, can be very high. And as mentioned, COVID-19 infection is also now recognized as a risk factor due to a hypercoagulable state it can induce.
Right. What about the inherited factors, like factor V Leiden?
Yes, hereditary thrombophilias.
Mm-hmm.
These include deficiencies of natural anticoagulants like protein C, protein S, or antithrombin, and genetic mutations like the prothrombin gene mutation and factor V Leiden. They definitely increase an individual's baseline risk.
Should everyone be tested for these?
Generally, no. Routine testing for these isn't practical or usually helpful for assessing risk in the acute setting when someone first presents with symptoms. However, if someone is known to have one of these conditions, that's valuable information. Some deficiencies carry quite a high risk of recurrence. There are also other conditions like elevated factor VIII levels or hyperhomocystinemia that might confer a slightly increased risk.
Okay, so we assess these risk factors, often using the Wells score. Can you remind us how that works?
The Wells criteria for DVT is the most widely used tool, especially for symptomatic outpatients. It assigns points based on clinical characteristics like presence of cancer, recent immobilization, localized tenderness, swelling, pitting edema, previous DVT, and actually subtracts points if an alternative diagnosis is considered just as likely or more likely.
And the total score puts people into risk categories.
Correct. Usually low, moderate, or high risk of having a proximal DVT. It's been validated in many studies and consistently stratifies outpatients effectively.
Do we know the approximate risk in each category?
Yes, a large meta-analysis provided some numbers. In a population where the overall DVT prevalence was 15%, the risk was maybe around 5% in the low-score group, jumped to about 17% in the moderate group, and was significantly higher, around 50–75%, in the high-score group.
But it's not perfect for everyone.
No, it can't rule out GVT definitively in all populations. It hasn't been validated in pregnant patients, for example, and its accuracy seems less consistent in hospitalized patients.
Okay. So we have the Wells score risk category. Now, how does that guide the testing strategy? What's the consensus approach?
The increasing consensus, based on a lot of evidence, is this. You start with risk stratification using the Wells score for patients classified as low or intermediate risk.
You do the D-dimer test.
Exactly. If that D-dimer comes back negative, using a high-sensitivity assay, the negative predictive value is extremely high, approaching 100% in some studies.
Meaning it's very unlikely they have a DVT.
Very unlikely. So, in most cases, no further imaging is needed for those low intermediate risk patients with a negative D-dimer. Now, most studies supporting this excluded patients with suspected PE or those already on anticoagulants, which is an important context.
Okay. And what about the high-risk group based on Wells, or those lower-risk patients who have a positive D-dimer?
They almost always proceed to imaging, typically duplex ultrasound. A negative D-dimer in a high-risk patient doesn't reliably rule out VTE, as we discussed.
And you mentioned potentially starting treatment even before imaging in high-risk cases.
Yes. If the clinical suspicion is high, based on a validated score or strong clinical gestalt, starting anticoagulation while awaiting diagnostic studies is generally recommended and considered safe, unless there's a very high risk of bleeding.
What about inpatients? You said Wells and D-dimer are less reliable there?
Correct. Most hospitalized patients tend to fall into the higher risk categories anyway. Both the Wells score accuracy and D-dimer performance, sensitivity and specificity, are generally lower in inpatients. Therefore, most hospitalized patients with suspected DVT will need confirmatory imaging.
So to quickly summarize the algorithm for outpatients or ER patients, low intermediate Wells score plus a negative high sensitivity D-dimer effectively rules out DVT. High Wells score or unvalidated risk assessment means proceed to imaging, likely without D-dimer first.
That's a good summary. and initiate anticoagulation promptly in the high-risk group awaiting imaging, barring contraindications.
We also talked about those adjusted D-dimer thresholds, age-adjusted or probability-adjusted.
Yes, those strategies can help increase the number of patients in whom DVT can be safely excluded without imaging, mainly by reducing false positives, particularly in older individuals.
Okay. Now, what about diagnosing DVT during pregnancy? You said the standard algorithms don't apply.
That's right, they shouldn't be used. The Wells score hasn't been assessed properly in pregnancy, and D-dimer levels normally rise throughout gestation, making the test much less useful.
Is there any specific tool for pregnancy?
There's something called the EFT rule, looking at left leg symptoms, calf circumference difference, and first trimester presentation. But it hasn't been prospectively validated and shouldn't be used alone to rule out DVT.
Does DVT present differently in pregnancy?
It often does, anatomically. There's a higher proportion of proximal iliac vein thrombosis, and it's more common on the left side, likely due to compression by the uterus and arteries.
So what's the recommended diagnostic approach?
Ultrasound, specifically including imaging of the iliac veins, is the preferred initial test. If that initial ultrasound is normal, but clinical suspicion remains high, guidelines recommend either repeating the ultrasound after a few days or considering MR venography.
And if DVT is confirmed?
Low molecular weight heparin, LMWH, is the preferred anticoagulant during pregnancy.
Got it. One last diagnostic challenge: determining thrombus age and diagnosing recurrent DVT. Can we tell how old a clot is?
It's very difficult. Clinical symptom onset is unreliable. Conventional imaging like ultrasound rarely helps determine the precise age.
Any promising techniques?
There's been some research on ultrasound elastography looking at the stiffness of the clot, but results have been inconsistent so far for routine use. Radio-labeled markers, or MRI, might give some indication if a thrombus is older, maybe 30 days or 6 months, but these are more relevant for differentiating acute on chronic changes in suspected recurrence, rather than aging a brand new clot. We still lack reliable tools for acute thrombus age.
And diagnosing recurrence in the same leg sounds tricky too.
Extremely challenging. The clinical presentation often mimics post-thrombotic syndrome, PTS, the chronic symptoms after a DVT, and imaging struggles to reliably detect new acute thrombus superimposed on existing post-thrombotic changes in the vein.
Does residual clot after treatment mean anything?
Residual thrombus is common after treatment completion and doesn't necessarily indicate treatment failure or predict future risk on its own.
Can D-dimer help with suspected recurrence?
A negative D-dimer in a patient with prior DVT who has a low clinical probability of recurrence can help exclude it. However, a negative result is less common overall in this population, which limits its clinical utility.
What about advanced imaging, like MRI or CTV for recurrence?
MRI might help differentiate active thrombus from older fibrotic changes after about 6 months, but neither MRI nor CTV has been rigorously tested or validated specifically for diagnosing suspected recurrent DVT.
So what's the bottom line for practice?
The bottom line is that clinical practice still relies heavily on conventional testing, mainly ultrasound, combined with good clinical judgment for both initial diagnosis and suspected recurrence, due to the limitations in clinically useful tests for thrombus age or specific validated approaches for recurrence.
Okay, that really highlights some ongoing needs. Let's shift fully into treatment now. Medical treatment of acute lower extremity DVT. What are the main goals here?
The primary goals are severalfold. First, stabilize the existing thrombus, stop it from growing. Second, prevent it from extending further up the leg or embolizing, breaking off and traveling to the lungs, causing a PE. Third, allow the body's natural fibrinolytic system to start breaking down the clot. And ultimately, reduce both immediate and long-term morbidity and mortality, including preventing or minimizing post-thrombotic syndrome.
And the main tool to achieve this is anticoagulation, blood thinners.
Absolutely. Anticoagulation has been the cornerstone of DVT treatment since, well, the early 1960s.
Have treatments changed much?
The biggest change recently is the advent of the direct oral anticoagulants, the DOACs. They've significantly increased the safety and feasibility of outpatient treatment for many patients with lower extremity DVT. People can often start treatment right away, even if imaging confirmation is slightly delayed.
But not everyone can be treated as an outpatient.
Correct. There are contraindications. Things like active bleeding, very high bleeding risk, severe symptoms suggesting major obstruction, significantly low platelet counts, thrombocytopenia, poor liver or kidney function, concerns about noncompliance with medication, or lack of adequate home support.
Besides the meds, what about non-pharmacologic measures? Elevation, compression?
Yes, those are often used. Early ambulation getting people moving is generally encouraged now, unlike the old days of strict bed rest. Leg elevation can help with acute swelling and pain. Compression therapy with stockings is also common, though as we'll discuss, the evidence for its benefit in the acute treatment phase specifically is a bit mixed, according to our sources.
Okay, let's focus on the anticoagulation. Does the location of the DVT proximal versus distal matter for treatment decisions?
Yes, it's a key consideration. For proximal DVT clots in the popliteal, femoral, or iliac veins, therapeutic anticoagulation for at least 3 months is the standard foundation of treatment.
Are there exceptions? Time is when more aggressive treatment is needed.
In certain specific severe cases, like Phlegmasia, cerulea, dolens, where the limb might be threatened, or very extensive iliofemoral DVT causing severe symptoms that started less than 14 days ago, and the patient has a low bleeding risk, there might be a role considered for thrombolysis, clot-busting drugs, or surgical thrombectomy, clot removal.
But is that common? What does the evidence show?
It's not common, and the evidence for routine use isn't strong. Large trials like CAVIT haven't consistently shown long-term benefits in reducing PTS or recurrence rates compared to anticoagulation alone. And catheter-directed thrombolysis, CDT, delivering the drug right to the clot via a catheter, carries an increased risk of bleeding.
So what do guidelines recommend for proximal DVT?
Current ACCP guidelines recommend anticoagulation alone over CDT for most acute proximal DVTs. CDT might be reserved for those limb-threatening situations, or potentially considered in younger, healthier patients with extensive iliofemoral DVT of recent onset, good functional status, long life expectancy, and low bleeding risk. But it's definitely not routine.
Okay. Now, what about those isolated distal DVTs, just in the calf veins? Management sounded more controversial there.
It is quite controversial. As we noted, PE is less common, and only about 15% extend proximally, usually within 2 weeks.
Is there trial data?
There was the Cactus trial, which is relatively small, underpowered. It randomized patients with distal DVT to either placebo or LMWH for 6 weeks. It found no significant difference in the rates of proximal extension, contralateral DVT, or PE. There was a non-significant trend towards more bleeding with LMWH, though.
So guidelines are likely conflicting.
They are. The 2016 ACCP guidelines suggest serial imaging, repeat ultrasounds, for 2 weeks over anticoagulation for patients with low risk of extension who don't have severe symptoms.
But they recommend anticoagulation for others.
Yes, they recommend 3 months of anticoagulation for those with severe symptoms or risk factors for extension. These include a positive D-dimer, extensive clot burden in the calf, clot close to the proximal veins, no reversible provoking factor, active cancer, prior VTE, or being an inpatient. Bleeding risk and patient preference are also key factors. If surveillance with ultrasound is chosen, anticoagulation is discouraged if there's no extension, but suggested if extension occurs.
Are there other guidelines?
Yes, some of the guidelines actually recommend 3 months of anticoagulation over surveillance for most distal DVTs, unless bleeding risk is very high. It's definitely an area where practice varies.
It sounds like a very individualized decision for calf DVT. Okay, let's dive into the anticoagulants themselves. You said they're the cornerstone. What are the main classes?
Right, anticoagulation reduces thrombus extension, mortality, recurrence, and the rate of post-thrombotic syndrome. We generally think about therapy in phases. Initial, first 5-10 days, intermediate after 3 months, and extended beyond 3 months.
And you start it right away if suspicion is high.
Yes. Anticoagulation should be initiated promptly upon high suspicion or confirmation, and shouldn't be delayed in high-risk patients while waiting for imaging, unless bleeding risk is prohibitive.
What are the options now? Historically, UFH, then VKA.
Correct. But now we have several initial options: LMWH, fondaparinux, another injectable, or starting directly with certain DOACs, rivaroxaban or apixaban. This allows outpatient management for many suitable patients.
But bleeding risk is always a concern.
Always. Before starting or continuing any anticoagulant, a thorough review of bleeding risk factors and a careful risk-benefit analysis are crucial.
What are some major bleeding risk factors?
Things like older age, over 65, history of a previous bleed, active cancer, especially with metastases, poor functional status, kidney or liver disease, low platelet count, anemia, recent surgery, frequent falls, alcohol use disorder, concurrent use of antiplatelet drugs or NSAIDs, and prior stroke.
Are there absolute reasons not to anticoagulate?
Yes. Absolute contraindications include severe, life-threatening active bleeding, like an intracranial hemorrhage. Relative contraindications might include severe thrombocytopenia, recent major trauma or bleeding, known bleeding disorders, endocarditis, or severely uncontrolled hypertension. The risk-benefit needs careful weighing.
Are there tools to predict bleeding risk?
Several clinical risk prediction scores exist, like HAS-BLED, RE8, VT-BLEED, but many were developed before DOACs became common. Their accuracy isn't always reproducible, and they aren't routinely used in everyday practice to guide decisions. Clinical judgment remains key.
And the risk changes over time.
Yes. After the initial 3 months, the decision for extended therapy involves balancing the 80–90% reduction in VTE recurrence risk against the ongoing bleeding risk, which, while perhaps lower per year than in the first 3 months, can have high case fatality if a major bleed occurs.
What if someone truly can't receive anticoagulation?
Options are limited. An IVC filter, preferably retrievable, might be considered to prevent PE, platelet transfusions if thrombocytopenia is severe, or perhaps prophylactic preventive dose anticoagulation if therapeutic doses are contraindicated.
What are the actual rates of major bleeding with treatment?
Overall, in the first 3 months, major bleeding rates are around 1–3%, maybe
Okay.
slightly lower, under 1%, with apixaban or rivaroxaban in trials. But the case fatality rate if major bleed occurs can be significant, maybe 5–20%.
Okay, let's quickly recap the specific drug classes. Unfractionated heparin, UFH. Why the monitoring need again?
UFH works indirectly with antithrombin to inhibit several clotting factors, but it binds nonspecifically to plasma proteins in cells, leading to unpredictable pharmacodynamics. Hence, the need for lab monitoring, APTT or anti-Zal levels, to maintain the therapeutic range. Failure to reach that range quickly is linked to higher recurrence risk,
And its main use now.
primarily for inpatients who might need procedures, have recent bleeding, severe renal dysfunction, extremes of weight, or as a bridge to warfarin, or for the initial 5 days before starting dabigatran or edoxaban. Drawbacks include the need for 5e infusion, monitoring variable response, and the risk of HIT.
Okay. Low molecular weight heparin, LMWH. Advantages.
LMWHs, like enoxaparin, dalteparin, are smaller fragments, mainly inhibiting factors A. They have much better bioavailability, more predictable response, longer half-life, given subcutaneously, less major bleeding, and maybe reduced mortality compared to UFH in trials.
Monitoring needed.
Not routinely. Dose adjustments and possibly anti-Ganza monitoring might be needed in severe renal insufficiency or obesity, but optimal management there is still being studied. LMWH was the standard for cancer-associated thrombosis, CAT, for a long time, being superior to VKAs, though DOACs are changing that landscape now.
Parenteral direct thrombin inhibitors, DTIs.
DTIs, argatroban, bivalirudin, directly inhibit thrombin. Their primary role in VTE is treating suspected or confirmed heparin-induced thrombocytopenia, HIT. If HIT is suspected, heparin is stopped, and a DPI is started pending confirmation. They're the only drugs specifically FDA labeled for HIT treatment as of 2020.
Okay. Vitamin K antagonists, VKs, like warfarin. The key things to remember.
VKAs inhibit production of vitamin K-dependent clotting factors, 2,7-9X, and anticoagulant protein CNS. They take days to work fully because they don't affect existing factors.
And that initial procoagulant risk.
Yes, because protein C, an anticoagulant, drops faster initially, there's a paradoxical procoagulant state. That's why warfarin must be overlapped with heparin LMWH for at least 5 days until the INR is therapeutic 2.0 on 2 readings 24 hours apart. Starting VKA alone is dangerous in acute thrombosis risks of clot propagation, skin necrosis.
And the monitoring burden.
Yes, narrow therapeutic window, variable response, dietary VIT-K, and numerous drug interactions, especially antibiotics, necessitate frequent PT-INR monitoring, targeting 2.0, 3.0 for VTE.
And finally, the direct-acting oral anticoagulants, DOACs. Remind us of the key features.
DOACs selectively target either factor, Xanico, rivaroxaban, apixaban, edoxaban, or thrombin, dabigatran. They have predictable pharmacokinetics, high bioavailability, fewer drug-food interactions than VKAs, and crucially, no need for routine monitoring.
Efficacy and safety compared to warfarin.
Large trials show they're generally non-inferior equivalent in efficacy to warfarin for VTE treatment. Safety was similar overall, but the Zavan inhibitors demonstrated significantly lower rates of intracranial and fatal bleeding.
And reversal agents exist now.
Yes, specific reversal agents are FDA approved for both classes in dexanet alpha for rivaroxaban apixaban and adagrasib for dabigatran for life-threatening bleeding or emergency surgery. Adagrasib only. Availability and cost are still limitations, though.
Can you briefly mention the key trials?
Sure. Einstein trials for rivaroxaban showed non-inferior efficacy and similar bleeding to LMWH VKA. Amplify for apixaban showed non-inferior efficacy and significantly less major bleeding. Hokusai VTE for edoxaban, given after initial heparin, showed non-inferior efficacy and superior safety regarding clinically relevant bleeding compared to warfarin. Recover trials for dabigatran, also after initial heparin, showed non-inferiority to warfarin with less major clinically relevant bleeding.
So strong evidence base. Any situations where DO-axers are not recommended for DVT?
Generally avoided in pregnancy, patients with triple-positive antiphospholipid syndrome, APS, or with concurrent use of strong inhibitors of certain metabolic pathways, CYP3A4P glycoprotein.
And cancer-associated thrombosis. COAs are options now.
Yes, this is a major shift. While LMWH was first line for decades, recent trials, Hokusai cancer, selected D, Caravaggio, showed safety and efficacy of edoxaban, rivaroxaban, and apixaban compared to LMWH for most CPOP patients.
So guidelines are changing.
Yes, major cancer organizations, NCCN and ASCO, now include oral VAG inhibitors as options for initial and extended treatment in SAT2, though careful consideration of bleeding risk, especially GI-GU cancers, and drug interactions is still crucial. The ACCP guidelines haven't been updated since these trials, so they still favored LMWH.
Okay. What about those adjunctive measures again? Compression stockings.
Right. While anticoagulation is key, things like leg elevation help acutely. Early ambulation is good. The role of graduated compression stockings, GCS, is debated.
Private debate.
Early studies suggested benefits in reducing pain and PTS, especially if started early. But the large, well-conducted SOX trial found routine use of GCS did not reduce PTS incidence compared to placebo.
So no role for them.
Not so fast. The ideal DVT study found personalized duration of compression, based on symptoms, was non-inferior to a fixed 2-year duration. And a sub-study hinted that early use, within 24 hours, might still be beneficial. Recent ACCP guidelines suggest against routine GCS specifically for preventing chronic PTS, but acknowledge they can be used for symptom relief, where a trial is often justified. More research is ongoing.
Okay, nuanced picture there. Finally, duration of treatment. How long?
Beyond the initial 3 months, it's all about balancing recurrence risk versus bleeding risk.
How do you estimate recurrence risk?
It depends heavily on whether the DVT was provoked by a transient factor like surgery or a persistent one like cancer, or unprovoked, no clear trigger. Unprovoked DVT has a much higher recurrence risk off anticoagulation, maybe 10% in the first year, compared to provoked DVT, maybe 1–3%.
Yeah.
Active cancer carries the highest risk. Initial treatment duration doesn't affect recurrence risk after stopping.
So who gets extended therapy?
ACCP recommend extended anticoagulation for unprovoked VTE with low-moderate bleeding risk, a second unprovoked VTE, and active cancer without high bleeding risk. Guidelines suggest risk stratification, using factors like sex, D-dimer levels after stopping, and annual reassessment.
Can specific factors predict recurrence?
Male sex, elevated D-dimer after stopping anticoagulation, residual thrombus burden, and proximal DVT site are predictors. Inherited thrombophilias like factor V Leiden are weak predictors alone. Protein C-santhrombin deficiency carry higher risk. Clinical prediction scores, Vienna-HER2O2, combine factors to help stratify risk after a first unprovoked event.
So general recommendations.
Usually 3 months for proximal DVT provoked by a major transient risk factor, possibly for isolated distal DVT if treated, or unprovoked DVT with high bleeding risk. Extended therapy for persistent provoking factors like cancer, or unprovoked DVT without high bleeding risk with annual risk-benefit review.
And for extended therapy, are there different dosing options?
Yes. Options include continued therapeutic dose anticoagulation, reduced dose apixaban, 2.5 milligrams twice daily, or rivaroxaban, 10 milligrams once daily, or potentially aspirin.
Reduced doses are as effective.
Trials like Amplify-ST and Einstein Choice showed these reduced DOAC doses were effective in preventing recurrent VTE, superior to placebo aspirin, without increasing major bleeding, in patients who had already completed 6–12 months of full-dose therapy and where continuation was uncertain. Whether these reduced doses are appropriate for all needing extended therapy, like active cancer, is still being studied.
And aspirin's role?
Warfasa and Aspire trials showed low-dose aspirin modestly reduced VTE recurrence versus placebo after stopping anticoagulation, without much bleeding increase. However, Einstein Choice showed rivaroxaban, both doses, was superior to aspirin.
So when use aspirin?
Perhaps most appropriate for secondary prevention in patients who finished anticoagulation are no longer candidates for it or have a separate indication for aspirin, but unacceptable bleeding risk on dual therapy.
This has been an incredibly thorough deep dive into DVT diagnosis and management. To wrap up, what are the main takeaways for our listeners?
I think for diagnosis, the key is integrating clinical risk assessment, often with tools like the Wells score, selective use of D-dimer, particularly in lower-risk outpatients, and relying on duplex ultrasound as the primary imaging modality.
Right.
And for treatment, anticoagulation is absolutely the cornerstone. The direct oral anticoagulants have really changed the landscape, offering effective, convenient, and often safer options. But tailoring treatment duration and approach based on whether the DVT was provoked or unprovoked, the location, patient factors like cancer or pregnancy, and crucially, balancing that recurrence versus bleeding risk is essential. It's very much about individualized care.
Absolutely. A really individualized assessment of risk and benefit seems critical. Thank you so much for walking us through all that complex information.
My pleasure.
And on that note, here's a final thought for you, our listener. Given all these advancements we've discussed today in understanding and treating DVT, what do you think might be the next major breakthrough? Will it be in preventing DVT from happening in the first place, perhaps through better risk prediction or targeted prevention? Or will it be in minimizing those long-term consequences like post-thrombotic syndrome? Definitely something to ponder. Join us next time for another deep dive.